Thank you. We're in the home stretch, just a couple more to go, then our panel. I just wanted to make a comment about my mother-in-law. I think the big boy Jerome, everyone knows, we've heard him before, he's usually quite eloquent, but he was a bit rattled today. His jokes didn't work out, he ran over time. And that was because he suffered a very heavy loss in golf a couple of weeks ago. I won't say about that. But now, you'll need your phones in a moment. I will have a question for you. And I got an SMS from Megan Smee, who's in Cairns with a group there. Some of you worked with Megan at UNSW. So good to see that the webinar's being used. And hello to our friends in Auckland. Your rugby team's going very well at the moment. And that's all I'll say about that. The notes of this talk are on page 27. So the non-operative management of glenohumeral joint osteoarthritis. So as a preamble, what I'd like to say is there is a paucity of evidence for this, and most of the treatments that are used or that you may use yourself are things you've adopted in your own management of hip and knee osteoarthritis. Some of the patterns of treatment, particularly ideas around rotatory range of motion return, tend to mimic hip treatment. But I would say to you, in all your patients who present with stiff and painful shoulders, and it will be said again more than once, please have them x-rayed. It's terrible to miss a diagnosis of glenohumeral osteoarthritis and treat it as something else. And as always, diagnosis and education is the starting point. So the etiology is multifactorial. By and large, it's seen more commonly in females than males in over 50 years. A Japanese group, a Korean group presented a large series showing that in over 15% of patients over 65 do have an abnormal X-ray, but because it's a non-weight-bearing joint, X-ray changes tend to develop late. So in terms of cause and classification, we have the familial and genetic types, and many of those patients will have other changes such as interphalangeal joint change and other primary joint arthritis. Post-traumatic is very common, so arthritis following instability or rotator cuff deficiency. And as John Green had pointed out, we do see other causes, so hemochromatosis, gout, and other inflammatory causes are there as well. So it's always worthwhile assessing our patients accordingly. So I'm going to ask you now, when you look at the evidence for exercise and physical therapy, so what is the evidence for exercise and physical therapy in the non-operative management of glenohumeral osteoarthritis, what do you think it is? Do you think the evidence is strong? Do you think the evidence is inconsistent? Do you think the evidence is weak? Or is there no evidence at all? So if you want to log that in. All right. Well, the actual answer overall is D, and it's interesting that we've got this sort of bell-shaped curve here. And I was quite surprised by this when I went through the literature preparing this. So let's go through it and go through the reasons why. Let's first of all look at what is the evidence for pharmacological treatment. There is good evidence for the use of analgesic and anti-inflammatory medications, and by and large the COX-2 anti-inflammatories seem to work best. And remember, most of these patients who are at the more severe end or have moderate severe arthritic change do have night pain. Intra-articular corticosteroid injections, there are many studies looking at this. A study by Kelly, a fairly large group, showed that for at least a 6-week period, about 2/3 of patients will have relief. I think the figure is a bit more than that, depending on what is done afterwards. And the key following an intra-articular injection, which needs to be done under imaging, so Paul, for example, will do it under ultrasound. Some radiologists do it under X-ray or CT scanning. The key really is that the shoulder should be protected for a 10-day period afterwards. So I say to my patients, you may feel quite good after day 2 or 3 from that potent anti-inflammatory effect, but take it easy with your shoulder, minimise the lifting you try and do, and certainly don't take your shoulder through full range of motion. The use of hyaluronic acid, there are 2 studies on that. So hyaluronic acid are products on the market such as Synvisc, OsteoArt's, Durolane and so on. There are no studies, independent studies, to look at its use in shoulder osteoarthritis. There are 2 industry-funded studies, one showing possible change, but the literature's not there. There are no studies looking at PRP effects. There are no studies looking at stem cell effects. I've had 2 patients I've seen one has had fat-derived stem cell, the other has had bone marrow-derived stem cell. One felt that he had some pain reduction for 3 or 4 months, but he was also on a lot of anti-inflammatories, so I think we can put a question mark there. There's no clear evidence on the use of supplements as well, such as the fish oil supplements and so on. But there is evidence that suprascapular nerve blockade does reduce pain. The suprascapular nerve does have a sensory component which does supply the glenohumeral joint. So on our multi-pronged approach, outside of pharmacology, what can we do? Well, I think a big thing really is load management, so managing the load of the shoulder. So people who have an exercise background, what can they do? So many patients we've seen may have post-traumatic osteoarthritis, and they've grown up doing weights where they've done bench press and push-ups and dips and shoulder press and so on. What can you do? And many patients still want to feel strong, want to have that sense that they can remain independent. So this is a main factor in the long-term health of the joint. But what we're trying to do also is delay their need for joint replacement. And Jerome will talk more to this point, but this is very different to the hip and the knee. The results of hip and knee replacement are quite predictable. We heard that some hip replacements may be lifelong, but certainly you can expect patients to have a good 15 or 20 years following a hip or knee replacement. It's not like that for the shoulder. It's shorter, and the other problem is that if you have repeat shoulder surgery revision, the results are far, far worse and the satisfaction rate is less. So ideally what we're trying to do is help patients maintain some strength, tone in the rotator cuff and maintain their range of motion without overloading the glenohumeral joint. And bearing in mind that by and large the first part of the glenohumeral joint that becomes arthritic is the posterior half of the glenoid, any movements where you're in abduction and external rotation will compress that part of the joint and obviously worsen the arthritic change. This is not the sort of problem where you're wanting to have the patient report pain as a guide, because the pain generally after you've done the wrong thing is a pain that occurs afterwards, that night or the next day, rather than immediate pain. So a lot of the resistance work will involve bands, pulleys, water-based exercises, and I put there as a question mark the use of a small abduction pillow. I'll come back to that, but I learnt this off 2 or 3 patients of mine who basically said to me, "Doc, when I do arm curls, if I put a little pillow or a towel under my arm in my armpit, it doesn't hurt at all the next day, and I'm really quite comfortable." So what they're referring to is using something as a lever to move the humeral head away from the glenoid, and a rolled up towel is enough to try and create some space, and certainly if you're not too stiff in the joint, that's a possibility. Now I do have a confession. At this same lectern in 2014, I presented a presentation on resistance training after major shoulder injury. But one of the things I've done very badly, particularly in my younger years as a sports physician, is I wasn't aware or serious enough of telling patients to unload their shoulder in abduction and external rotation, particularly after instability injuries. We often see a scenario where the top of the glenoid will have damage, arthritic change that occurs with recurrent instability in the shoulder, and people think they can keep doing this. So let's talk about physical therapy. With the physical therapy, there are 2 papers that I've referenced. The paper by Izquierdo is published by the American Academy of Orthopaedic Surgeons in 2010. It's a very good review article and freely available. and the second one by, and apologies to Mel Cusey if I get this wrong, it's a Mexican group, Macias Hernandez, recently published in a disability journal online. I think it's a non-refereed journal, has very complicated and inappropriate exercises, but it has a very good overview of the causes of osteoarthritis. So basically there's very little evidence. We're trying to improve range of motion and strength, but what you're trying to do is recenter the humeral head, bearing in mind that your healthy glenoid is much smaller than it was. So you may have half your glenoid arthritic. It's very, very difficult. So pushing range of motion and compressing the joint may create flare-ups. So your physical therapy will depend on the degree of arthritis in the joint and also the integrity of the rotator cuff. So there are 4 considerations I'm going to quickly give you, but I'd like to make the point that there's no program, it's so individualised. And I'd also like to say to you, particularly with respect if you're a younger physiotherapist, if you're working in a practice with someone more experienced, this is the type of condition where experience counts for a lot. So seek the advice of your more experienced colleagues. So the first thing, is the humeral head centred? So many patients have pain lying down, they have an ache. Can they get themselves in a position where they feel more comfortable themselves? Can you help them do that? Once you've achieved that, offer them isometric control of their shoulder just by retracting their scapula to try and hold that position. So doing isometric exercises in the prone position may be helpful. Second and thirdly, and these are expanded in the notes, what is the main capsular restriction and is there any associated musculoskeletal dysfunction? So we're trying to improve range of motion without taking the patient into abduction because that will hurt them. It has to be patient controlled. By and large, patients will report, and studies have shown that if you do this when they're warmed up, so heat, massage or exercises prior to that is more comfortable. And gravity is your friend. So there's a picture of the very old pendular stretchers, remember them? Well, the Mayo Clinic and the Harvard Medical School website has that as their preferred stretch for osteoarthritis of the shoulder. It's still there, it still exists. And you may want the patient to use a weight in their arms, starting with a 1 kg as general traction, taking the shoulder into counterclockwise and clockwise rotation. And just before I finish, where is most of the weakness? Well, balancing the rotator cuff is the key. It has to be pain-free and maintaining good scapular control. And this is where you can use a small abduction pillow, I would suggest. So there's a good study out there for any of you to look at low-level exercise with an abduction pillow and pain responses. So finally, there's very little evidence in the management of non-operative treatment of glenohumeral arthritis. As we seek to diagnose and educate the patient, let's keep in mind this 3-pronged attack, and the response varies, and all treatment should be individualised and altered as needed. Thank you.